55 ஆகுது. சவுண்ட் ரொம்ப வரும். ஒரு 8க்குள்ளே ப்ரீவியஸ் இயர் டாபிக்ஸ்லாம் பார்த்துட்டு ப்ளஸ் மெடிசனோட ஒரு சாப்டர் அதையும் வந்து நம்ம ரீட் பண்ணி முடிக்கணும். கொசு அக்யூட் ஸ்டமி பற்றி நம்ம பார்க்கணும். பேத்தோஜெனிசிஸ் மெக்கானிசமு, கிளினிக்கல் ஃபீச்சர்ஸு, இசிஜி ஃபைண்டிங்ஸு, கார்டியாக் பயோமார்க்கர்ஸ் அண்ட் இன்வெஸ்டிகேஷன், காம்ப்ளிகேஷன்ஸ், இமிடியட் மேனேஜ்மெண்ட், ட்ரக்கு, ரீபெர்ஃபியூஷன் தெரப்பி, லாங் டைம் மேனேஜ்மெண்ட். ஸோ பேத்தோஜெனிசிஸ் அண்ட் மெக்கானிசம். Sudden and complete coronary artery block leading to full thickness. Sudden and complete coronary artery block leading to full thickness, transmural heart muscle damage. So pathogenesis is sudden and complete coronary artery block leading to full thickness, transmural heart muscle damage, coronary artery occlusion, abrupt occlusion of vessels, RCA, VAD, CX causes corresponding tertiary infarction. Complete coronary artery block leading to full thickness, transmural heart muscle damage, coronary artery occlusion, abrupt occlusion of vessels, right coronary artery, left anterior descending artery. Lipid rich core, vulnerable atherosclerotic plaque with a lipid core and a thin fibrocellular capsule. Vulnerable atherosclerotic plaque with a lipid core and a thin fibrocellular. Overlying thrombosis, mechanical stress, rupture, fissure, erosion, exposes plaque contents, triggering intense platelet aggregation and superimposition thrombosis. Tissue necrosis, prolonged blood absence lead to the irreversible myocardial necrosis, expands over several hours frequently. Hello. Dylan Romano 5X. Thank you, thank you. Cardiac pain, autonomic disturbance, impaired mental function, notable associated symptoms. Prolonged cardiac pain, excruciating tightness, heaviness or constriction, radius to the throat, arms, epigastrium or back. Excruciating tightness, heaviness or constriction, radius to throat, arms, epigastrium or back. Autonomic disturbance, sympathetic feedback, sympathetic reaction takes place in case of usually there will be sympathetic response, parallel sweating, tachycardia. But in case of inferior MI, there will be a vagal response, severe nausea, vomiting, and bradycardia. signs of hypotension, oliguria, cold peripheries. Cold peripheries இருக்குது, hypotension இருக்குது, failing pump, hypotension, oliguria, cold peripheries, raised JVP, quiet S1 and audible S3. Quiet S1, audible S3, raised JVP, cold peripheries, hypotension, failure of failing pump. Notable associated symptoms: intense breathlessness, anxiety, syncope or collapse, fear of impending death. Electrocardiogram, ECG. ECG changes. First we saw about pathogenesis. Pathogenesis, there will be pathogenesis and mechanism of acute stenosis. So pathogenesis and acute mechanism of stenosis consists of 4 mechanisms. Coronary artery, total occlusion of coronary artery. Lipid-rich core, that coronary artery occlusion substances, lipid-rich core consists of lipid-rich core, and it contains overlying thrombosis because it contains mechanical stress, rupture, fissure, erosion, exposure plate contents, triggering intense platelet aggregation and superimposed thrombosis, and it contains tissue necrosis products. Tissue necrosis means not necrosis. Heart tissue necrosis means here tissue indicates heart. So prolonged blood absence leads to irregular myocardial necrosis. Expanse over several hours. Prolonged cardiac pain, excruciating tightness, heaviness or constriction radiates to throat, arms, epigastric or back. Autonomic disturbance, sympathetic. So mechanism and pathogenesis, coronary artery occlusion, consists of lipid core, overlying thrombosis, tissue necrosis, Clinical features consist of pain. Pain is P is prolonged cardiac pain. Prolonged cardiac pain. That prolonged cardiac pain radiate to epigastrium or arms. It may be throat, so it may be wherever it can radiate. Excruciating chest tightness will be there. Autonomic disturbance also will be there. Autonomic disturbance usually sympathetic involves sympathetic response. Sympathetic response involves pallor, sweating, tachycardia. In case of inferior auditory, it involves vomiting and bradycardia. Severe nausea, vomiting and bradycardia. Next, impaired myocardial infarction function. Signs of failing pump. So there will be hypotension and there will be a cold peripheries, oliguria, absent S1 or reduced S1 sound, and there can be S3, hearing of S3 sound, audible S3. Notable associated symptoms. Associated symptoms will be intense breathlessness will be there. Anxiety, syncope or collapse, fear of impending death. Electrocardiogram changes, ECG waves. Predictable sequence indicator of transnodal infection. ECG changes wave, dynamics wave. Predictable sequence indicative of transnodal infection. Predictable sequence indicate of transmural infection. Predictable sequence indicate of transmural infection. Widespread ST elevation, anatomical localization, ventricular Q-waves develop, evolution of T waves. Widespread ST elevation, earliest sign, current of injury, ST more than 1 mm limb leads or more than 2 mm contiguous chest leads, a newly developed left bundle branch block. So we all know there will be ST elevation in case of acute. That is only the topic is acute STEMI. So if the ST elevation is more than 1 mm, that is earliest sign of current of injury. More than 1 mm. There is a ST elevation of more than 2 mm contiguous chest leads. It is a newly developed left bundle branch block. Anatomical localization. Specific leads pinpoint the for V1 to V4. Anteroseptal 2-3 AVF inferior reciprocal ST depression usually in opposite leads. Anatomical localization specific lead points specific lead pinpoint the for V1 to V4. சாரி அர்ஜென்ட்டாக வந்து சொல்லிட்டு வந்துட்டேன். எப்படி முடிக்க போகிறதெல்லாம் நிறைய இருக்குது. இவ்வளோ ஒரு சின்ன யூனிட்டை வந்து முடிக்கணும்னு நினச்சேன். ஒரு டாபிக் படிக்கிறதுக்கே டேக்கிங் டைம். ஓகே ஸ்பெசிஃபிக் லீச் பின் பாயிண்ட் இன்ஃபேக்ட் V1 to E4 தெரிஞ்சது அப்படின்னா ஆண்ட்ரோசெப்டர். V1 to E4 லீச்சில் வந்து லோக்கலைசேஷன் ஆகி எஸ்டி எலிவேஷன் இருந்துச்சு அப்படின்னா V1 to E4 லீச்சில் ஆண்ட்ரோசெப்டர் 2-3 AVF லீச்சில் வந்து லோக்கலைசேஷன் ஆச்சு அப்படின்னா அது வந்துட்டு இன்ஃபீரியர். Reciprocal ST depression seen in opposite leads. Particular theories developed progressive loss of organs and development of deep pathological theories, established necrosis. So V1 to V4 develop if the in fact is if the ST elevation is in the V1 to V4 currently, there is a ST elevation in the V1 to V4 leads, there will be an antroceptor. If there is a ST elevation in 2-3 AEF leads, there will be an inferior one. 2-3 AEF leads, there will be inferior one. Reciprocal ST depression seen in opposite leads. So if there is an androseptal MI means V1 to V4, there will be changes in V1 to V4. If there is a inferior wall MB, there will be changes in 2-3 AVS fluids. Reciprocal ST depression seen in opposite fluids. Ventricular Q waves develops. Progressive loss of R waves. Q or ST. P wave, Q wave, R wave. Progressive loss of R waves and development of deep pathological Q waves is equal to established necrosis. R wave வந்து லாஸ் ஆகி டெவலப்மெண்ட் ஆஃப் டீப் பேத்தாலஜிக்கல் Q waves டெவலப் ஆச்சு அப்படின்னா இட்ஸ் இண்டிகேட்ஸ் ஆஃப் எஸ்டாப்ளிஷ்ட் நெக்ரோசிஸ். Pathological Q waves develop established necrosis. Pathological Q waves is equal to established necrosis. Evolution of T waves. Evolution of T waves. Terminal T wave inversion. Terminal T wave inversion occurs due to altered repolarization persist long after acute phase. Evolution of T waves. Terminal T waves inversion. Terminal T waves inversion occurs due to altered repolarization persist long after acute phase. Cardiac biomarkers and investigation. Cardiac biomarkers and investigation test. Confirm myocardial necrosis and evaluate cardiac function. Troponin TRI rise or fall deteriorate 3 to 6 hours. Peaks 36 hours. Requires more than one value above the 99th percentile. Enzyme sequential rise of creatinine kinase, AST and lactate dehydrogenase. Supportive findings: leukocytosis peak day 1, increased TSR, CRP, lipid filtration within 24 hours. Transthoracic echo and X-ray. Chest X-ray leads to assess hidden pulmonary edema. Echo to assess left ventricular function, neural thrombus, mitral regurgitation or septal defects. So cardiac biomarkers and investigation. Test EMPC test. Troponin T and I rise or fall detectable 3 to 6 hours, peaks in 36 hours. Requires more than one value above the 99th percentile. Enzyme sequential rise of creatinine kinase. So widespread ST elevation, earliest sign, current of injury, ST elevation more than 1 millimeter. Okay, that is low. Development of ventricular Q waves, that is pathological Q waves, is equal to established necrosis. Evolution of T waves, terminal T waves inversion because due to the altered repolarization persists long after acute phase. Cardiac biomarkers and investigations. Confirm myocardial necrosis and elevate cardiac function. Troponin T or I rise or fall detectable 3 to 6 hours, peaks in 3 to 6 hours. Requires more than one value above the 99th percentile. Enzymes sequential rise of creatinine kinase, AST, sequential rise of creatinine kinase, AST, lactate dehydrogenase, sequential rise of creatinine kinase, AST, lactate dehydrogenase. Supportive findings: leukocytosis peak day 1, increase in ESR, CRP, lipid profile checked within 24 hours, transthoracic echo and X-ray, chest X-ray to assess hidden pulmonary edema, echo to assess LV function, neural thrombus, transthoracic echo எடுக்கணும், X-ray எடுக்கணும். X-ray வந்துட்டு to find hidden pulmonary edema, echo எதுக்கு எடுக்கணும்னா LV function பண்ணுறதுக்கு, neural thrombus, mitral regurgitation, septal defects. Supportive findings: glucocytosis இருக்கும், டே 1 பீக் ஆகும் glucocytosis, அடுத்து இன்க்ரீஸ் இன் ESR இருக்கும், CRP இன்க்ரீஸ் ஆகும், லிபிட் ப்ரொஃபைல் செக் வித்தின் 24 hours. என்ஜைம்ஸ் வந்து சீக்வன்ஷியல் ரைஸ் ஆஃப் சிகேஎம்பி தான் மோஸ்ட் காமனாக சிகேஎம்பி தான் ரைஸ் ஆகும், அடுத்து AST, ALT, லாக்டேட் டீஹைட்ரேஷன்ஸ் வந்து இன்க்ரீஸ் ஆகும். ட்ரோபோனின் TME வந்துட்டு 3 to 6 hours வந்து ஒரு ரேபிட் ரைஸ் இல்லை ஃபால் இருக்கும், 36 hours பீக்காக இருக்கும். ரெக்வஸ்ட் மோர் தென் ஒன் வேல்யூ அபோவ் தான் 99%. Acute complications: MA on acute complication, life-threatening mechanical, inflammatory and ventricular failures. So fatal arrhythmias, ventricular fibrillation, early sudden death, atrial fibrillation ஆகலாம், ventricular fibrillation, இது வந்து fatal arrhythmias. இல்லை ஏவி பிளாக் இருக்கலாம், ஏட்ரியல் வென்ட்ரிகுலர் பிளாக். அடுத்து அக்யூட் ஹார்ட் ஃபெயிலியர், லெஃப்ட் வென்ட்ரிகுலர் ஃபெயிலியர் லீடிங் டு பல்மனரி எடிமா அண்ட் கார்டியோஜெனிக் ஷாக். இன்ஃப்ளமேட்டரி கண்டிஷன்ஸ், அக்யூட் பெரிகார்டிட்டிஸ் 2 to 3 டேஸ்க்கு அப்புறமா அக்யூட் பெரிகார்டிட்டிஸ் ஆகலாம். ஏன்னா நெக்ரோசிஸ் ஆகுது, நெக்ரோசிஸ் ஆனால் இன்ஃப்ளமேஷன் ஆஃப் கார்டியாக் பெரிகார்டியம், இன்ஃப்ளமேஷன் ஆஃப் பெரிகார்டியம் மட்டும் கொடுக்கலாம். ஆனால் ஓகே, அதுக்கடுத்து டெஸ்ட் acute autoimmune pleurisy weeks or months later, inflammatory conditions, acute pericarditis, lesions or ruptures, papillary muscle rupture on acute mitral regurgitation, ventricular septum rupture, left to right shunt, ventricular free wall rupture, fibroid tamponade, late stage ventricular remodeling or annulation, left ventricular failure leading to pulmonary edema or cardiogenic shock, inflammatory conditions, acute pericarditis 2 to 3 days. Lesser symptom, autoimmune pericarditis weeks or months later. Pericarditis full lesser symptom autoimmune weeks or months later. Lesions and ruptures, papillary muscle rupture, acute mitral regurgitation, ventricular septum rupture, left to right shunt, ventricular free wall rupture, fatal tamponade, late stage ventricular remodeling and annulation. Immediate medical management, drug. Urgent admission for pain relief and medical stabilization, dual antiplatelet therapy, relief of pain and anxiety, unload the heart, guard against arrhythmias. Weeks or months autoimmune left ventricular failure leading to pulmonary edema and cardiogenic shock, lesions of papillary muscle rupture ஆகும், acute mitral regurgitation எம்மாகுது, ventricular septum rupture, ventricular septum rupture வந்துட்டு left to right shunt, ventricular free wall rupture வந்து fatal tamponade, late stage வந்து ventricular remodeling or annulation. Admission of pain relief and medical stabilization. Pain relief வந்து urgent admission போகணும், urgent admission for pain relief and medical stabilization. Dual antiplatelet therapy போகணும், dual antiplatelet therapy, load immediately with aspirin 300 mg, load aspirin with 300 mg plus ticagrelor 180 mg or clopidogrel, ticagrelor or 180 mg or clopidogrel, dual antiplatelet therapy கொடுக்கணும். In case of acute myocardial infarction, we need to give immediate medical management where the mnemonic drug dual antiplatelet therapy, dual antiplatelet therapy, that is aspirin 300 mg plus clopidogrel 80, ticagrelor 180 mg or clopidogrel 300 mg, aspirin 300 mg plus ticagrelor 180 mg, ticagrelor 180 mg or clopidogrel 300 mg. So relief, then dual antiplatelet therapy first do over. Next relief of pain and anxiety, IV OPH morphine 5 to 10 mg plus diamorphine 2.5 to 5 mg, antiemetic metoclopramide. Unload the heart, nitrate sublingual, there is associated hypertension, unload the heart, nitrate sublingual or IV or ischemia or LV failure plus high flow oxygen if hypoxemic is high flow oxygen. Guard against arrhythmias, IV beta blockers reduces infarct size, avoiding heart failure, severe hypotension, bradycardia. We should avoid IV beta blockers, reduces the infarct size, but we should avoid in hypotension and bradycardia and heart failure. So first we need to do give in case of acute in case of STEMI, acute STEMI, we need to what are the drugs we have to give. The mnemonic is drug dual antiplatelet therapy. Dual antiplatelet therapy consists of aspirin, which is we have to give 300 milligram of aspirin plus ticagrel, either ticagrel 180 milligram or clopidogrel 300 milligram. That is a dual antiplatelet therapy. Next we have to give relief of pain. We need to reduce pain and anxiety. For that we have to give morphine, which is 5 to 10 milligram, or diamorphine 2.5 to 5 milligram. Plus we need to give the antiemetics, that is metoclopramide. Next we need to give we need to unload the heart with we need to unload the hypertension. We need to unload the heart. It is given like that, but we need to reduce the hypertension. That is by giving sodium nitroglyceride nitrates. That is we need to give nitrates, sodium nitrate. We need to give just nitrates. That is sublingual or IV, and if and it is for given ischemia or LV failure. Nitrates are given for LV heart failure drugs. Unload the heart means we basically in acute STEMI there will be a failure of heart to pump. So we need to reduce the heart load by giving nitrates. There will be a reducing of LV ischemia, left ventricular ischemia, or left ventricular failure. Left ventricular failure, LV ischemia, and we need to give high flow oxygen if there is a hypoxemic. G is guard against arrhythmias. IV beta blockers. We need to give in case of we need to prevent arrhythmia means we need to give IV beta blockers, but it is contraindicated in case of heart failure, hypotension, and bradycardia. It reduces the infarct size. So the mnemonics drug. First we need to give dual antiplatelet therapy, that is aspirin 300 mg plus ticagrelor, TACAGRELOR, ticagrelor 180 mg, or clopidogrel, that is 300 mg. This is dual antiplatelet therapy. Next we need to relieve pain and anxiety, that is by giving opiates, that is morphine 2.5 mg, 5 to 10 mg, or diamorphine, that is 2.5 mg to 5 mg. That is morphine is 5 to 10 milligram. That is, then the diamorphine is 2.5 to 5 milligram. It reduces the anxiety, it reduces the pain, and we need to give metoclopramide. That the dose not given. Metoclopramide we have to give one tablet, and U is okay. Then we can tell G first. Guard against arrhythmias. Guard against arrhythmia is to give IV beta blocker. It reduces the size of infarct as well as it reduces the but it should be avoided in case of heart failure, hypotension, bradycardia. U is unload the heart. Unload the heart means we need to reduce the heart hypertension. That is by giving nitrates sublingual or into IV. It reduces the LV load as well as the heart failure features. LV ischemia as well as heart failure features. And we need to give high flow oxygen if there is a hypoxemia. Reperfusion therapy. First we need to give medical therapy, immediate medical management, then we need to give reperfusion therapy. Diagnosis through ECG and cardio biomarkers and investigations, and patient come with clinical features, pain, pathogenesis, mechanism of clot. Reperfusion therapy target primary PCI, intravenous thrombolysis, medical anticoagulation, early rescue angiography. Rapid restoration of coronary blood flow dramatically limits infarct size. For long-term management, we need to see about cholesterol lifestyle, AC inhibitors or ARBs, and receptor antagonist and extended therapy. These are the long-term management. The mnemonic is care, cholesterol and lifestyle, AC inhibitors and ARBs, receptor antagonist and extended therapy. Infarcts target primary PCI, balloon dilatation and stenting is treatment of choice if within 20 minutes of symptoms onset. Intravenous thrombolysis, connective place, septic place given immediately if PC is more than 120 minutes, if no bleeding risk. Medical anticoagulation, subcutaneous fondaparinux or LMW heparin. So reperfusion therapy, time, target primary PCI, balloon dilatation, stenting is treatment of choice. Balloon dilatation and stenting is treatment of choice within 120 minutes. Within 120 minutes of symptoms and onset. Intravenous thrombolysis, connective place, reactive place given immediately if PCI is more than 120 minutes, no bleeding risk. Medical anticoagulation, subcutaneous fondaparinux or low molecular weight heparin, IV GP2P or 3 inhibitors for high risk percutaneous coronary intervention. Early rescue angiography, routine early percutaneous coronary intervention within 24 hours even if thrombolysis is successful. Balloon dilatation and stenting is the treatment of choice if within 120 minutes of symptoms are onset. So if the patient comes within 120 minutes of symptoms are onset, then balloon dilatation and percutaneous balloon dilatation and stenting. Balloon dilatation and stenting is the treatment of choice if the patient comes within 120 minutes of symptoms and onset. The patient comes within 120 minutes of symptoms and onset. In case of acute STEMI, if the patient comes within the 120 minutes of STEMI or as symptoms of STEMI, then balloon dilatation and stenting is the treatment of choice. Intravenous thrombolysis, tenactic place, seti place, given immediately if PCA more than 120 minutes, if no bleeding risk. Uh, Medical management, anticoagulation, subcutaneous fondaparinux, and low molecular weight heparin. Intravenous tenactic place, seti place, if no bleeding risk. First we need to give medical management, then we need to give reperfusion therapy. Reperfusion therapy is rapid restoration of coronary blood flow dramatically limits the infarctions. First we need to give medical management, that is we need to dilate the coronary blood vessels by giving medical drugs, and we need to kill that we need to remove that infarct by giving medical drugs. Here it is reperfusion therapy, that is increasing the heart vessels, increasing the blood to the heart vessels, or increasing the perfusion to the heart by increasing the heart blood flow by doing reperfusion therapy. Here we need to give target primary PCA. First we need to give target primary PCA, that is if the patient comes within 120 minutes of acute STEMI, then the patient develops, then we can give not patient develops, then we can give balloon dilatation and stenting. Balloon dilatation and stenting is the treatment of choice if the patient comes within 120 minutes of symptoms onset, that is 2 hours of symptoms STEMI, then we can give balloon stenting and dilatation, that is target primary PCA. Then we need to give anticoagulant therapy, that is we need to give alteplase, tenacteplase, if there is no bleeding risk, and the target PCA is more than 120 minutes. If the patient comes more than 120 minutes, then we need to give target PCA. Along with that, we need to give anticoagulant therapy, that is tenacteplase and alteplase. If there is a high risk, here we are giving intravenous anticoagulants because tenacteplase and alteplase we are giving only because intravenous thrombolysis we are doing. Intravenous thrombolysis we are doing. We are using tenacteplase, alteplase. If PCA is more than 120 minutes, only if there is a lesser bleeding risk. If there is a higher bleeding risk, then we need to give medical anticoagulants. That is fondaparinux and GP2B and 3A inhibitors. GP2B or 3A inhibitors for high risk PCA, and we need to give low molecular weight heparin or fondaparinux, that is subcutaneous for fondaparinux, medical anticoagulants. Then early rescue angiography, routine early PCA within 24 hours of thrombolysis, even if thrombolysis is successful. we need to give 24 hours of, within 24 hours we need to give LEPC. Long term management, we need to long term medication, lifestyle, and to prevent recurrence. Cholesterol lifestyle, intense statin therapy, atorvastatin 80 milligram, stop smoking, Mediterranean diet, and weight control, rehabilitation. Cholesterol lifestyle, intense statins therapy therapy. That is, we need to give atorvastatin 80 milligram, and we need to give stop smoking and Mediterranean diet and weight control, rehabilitation. AC inhibitors, and ARVs, counteracts late ventricular remodeling, prevents heart failure, improves survival. Cholesterol and lifestyle, intense statin therapy, atorvastatin need to give 80 milligram, and stop smoking, and Mediterranean diet and weight control, rehabilitation. AC inhibitors and ARVs, counteract left ventricular remodeling, prevent heart failure, improve survival. KR receptor antagonist, spironolactone epilonin added if LV ejection fraction is less than 35% with heart failure or diabetes. Extended therapy, lifelong beta blockers, 25% mortality reduction, dual antiplatelets up to 12 months. Dual antiplatelets is already saw now, aspirin 300 milligram, or ticagrelor that is 180 milligram, or clopidogrel that is also 300 milligram. Ticagrelor, TACA, tica, GRE, LOR, ticagrelor. பேசு தலைவாவா. நானே டயர்டாகிட்டேன் படுத்து, நாளே முடியல. இது வந்து ஸ்டடி வித் மீ சீரியஸ்னு போட்டுருக்குன்னா இதில் பேசக்கூடாது யூஸ்வலாக. அப்படியே அவன் படிக்கிறது வந்து அப்படியே சும்மா இந்த மாதிரி 4 பேர் பார்த்தாங்கன்னா எனக்கு ஒரு சப்போர்ட்டாக கிடைக்கும். லாண்ட்ரி ரூம் தான் புரியல.
ஓகே பாய். இன்னையோட இதை முடிச்சுக்கலாம். நாளைக்கு ரொம்ப கண்டிப்பாக பண்ணுவோம்.